Okay, go.
Hi, my name is Gretchen Welch. I'm the Regional Manager of Upstate New York, and I'm bringing you this week's The Right Way Wednesday. Today we're talking about documenting a skilled daily treatment note. The primary component of a skilled daily treatment note is the skilled intervention that you as a clinician provided that day during your treatment. Other components of the skilled daily treatment note include patient's response to therapy, patient's subjective report, modifications or adaptations to your treatment plan moving forward due to progression towards goals or potentially lack of progression towards goals, and also caregiver training. The primary component of your skilled daily treatment note of skilled intervention is more than just ADL retraining, gait retraining, and transfer training. For ADL retraining, what are you doing that is skilled? Are you providing adaptive equipment training? Are you teaching body mechanic modification to decrease the potential for pain? Maybe you're teaching integration of energy conservation into the ADL routine. For gait retraining, what are you doing? Are you teaching the patient increased step length, or are you educating the patient on equal weight distribution during stance phase? For transfer training, are you educating the patient on transferring their center of mass over their base of support? Documenting your skilled intervention allows the reader to clearly understand what you are doing that is skilled during your daily treatment. To help illustrate this point, I have pulled two clinicians to read to you their daily treatment notes. My first clinician is Kalina Kiernan, occupational therapist.
Patient appeared to be in good spirits this morning and reported no pain or feeling of shortness of breath this morning on 2 liters of oxygen. Patient participated in ADL retraining to enhance patient ability to complete lower body dressing and footwear management with focus on modified dressing techniques. This writer demonstrated modified lower body dressing techniques with use of adaptive equipment. Patient return demonstrated modified technique with standby assist. This writer also demonstrated modified techniques to don and doff socks and shoes with use of adaptive equipment. Patient return demonstrated modified technique with minimal verbal cues with increased time. Throughout ADL retraining, this writer educated patient on energy conservation techniques, implementing therapeutic rest breaks to assist with managing fatigue and shortness of breath.
Thank you, Kalina. Next, Sam Vanini, PT, will read to you one of his daily treatment notes.
Patient was agreeable to physical therapy and requested to remain in room for treatment session. Patient reported not sleeping well last night, which is affecting energy level today. Patient was instructed in sit-to-stand transfer training from non-elevated recliner chair to facilitate increased independence with transfers. Writer provided tactile cues for anterior weight distribution to transition body weight over base of support with both hands pushing from the armrests. Patient was unable to overcome the posterior bias, thus requiring moderate assist. Assistance was provided from therapist which decreased to minimum assist when technique was modified to adjust hand position of right hand on walker with left hand on the armrest of the chair, as this allows patient to initiate anterior pelvic tilt prior to standing. Patient was able to provide consistent return demonstration throughout the session of verbal and tactile cues to minimize posterior bias and retropulsion with transitional movements. Patient was further instructed in stand pivot transfer training with rolling walker from recliner to bed to facilitate increased independence and decreased reliance on nursing staff. With moderate assist and tactile cues provided, patient demonstrated the ability to weight shift ipsilaterally to advance the contralateral lower extremity with rolling walker and requiring dependent assist for oxygen tube management. Directional input was required throughout the transfers for walker management with turns and up to maximum assist for stepping posteriorly to approach chair. Patient displayed inability to self-correct balance losses due to the narrow base of support and forward flex posture. Patient exhibited no shortness of breath during the session, and oxygen saturation was greater than 93% throughout treatment. Patient continues to demonstrate consistency with transfer training with less than 2 assists and will be appropriate to begin caregiver training with the primary CNA to facilitate progression of nursing recommendations to 1 assist with the staff.
Thank you, Sam. Thank you for viewing this week's The Right Way Wednesday. Bye-bye.